Good day, everybody, and welcome to this session of the Brain Conference that is focused on epilepsy and parasites in low and middle income countries. The program is as follows. We're going to have several speakers that have been chosen for you from around the world. We'll have Professor Paul Seke that will be talking about experimental models of epilepsy. And then we would have a genomic profile of a South African inherited myopathies. And then we would have clinical and translational research in epilepsy by Professor Gagandeep Singh, who is president of the Indian Academy of Neurology. And then you have epilepsy in low and middle income countries, challenges and perspectives by Professor Lay Sander, who is a great leader in epilepsy globally. We'll have optical genome mapping, molecular diagnosis of Facioscapulohumeral muscular dystrophy, advancement and challenges, which is a teaching talk. And then we would have a session at the end of these presentations. Just write down your questions and you can put them in the chat box so that we will have the discussion during the question and answer session. Epilepsy is a very serious condition with about 50 million people around the world suffering from it. Most of these people suffering with epilepsy are in low and middle income countries, where the treatment gap is very, very wide. And this is the challenge we have. You are all welcome, and thank you for being here.
Warm greetings, dear colleagues. My name is Paul Seke from Cameroon, University of Garoua. I will talk about models of epilepsy in low and middle income countries. Experimental models of epilepsy in LMICs. First of all, the context of LMIC is marked by lack of financial resources. So there's inadequate research funding and capacity for research institutions. And the direct consequence of that is the difficulty to find equipment, difficulty to find reagents, consumables, and also the lack of skilled personnel. Because if you do not have money, how can you recruit? And so you do not have other researchers that can work with you as assistants or in any other capacity. And you do not have technicians, which is a big issue because you have to do everything yourself. And it limits what you can do because collaborations are not easy also because due to the distance and also to administrative hurdles, as you mentioned in a few, we discussed in a few. You also have pronounced gender disparities. So even if you have brilliant female students, it's not always easy to convince her to go for a PhD. They will stop at master, usually stop before master, somewhere there, due to political or, I don't know, to cultural reasons. You also have language barrier in the sense that most researchers in low and middle income countries are not English native speakers. So it is difficult for them to, or it can be difficult for them to understand what is written in papers because most papers are in English. Epilepsy is a serious neurological disorder characterized by abnormal, recurrent, and synchronous discharges in the brain, which can cause serious damage to brain function as observed in patients with temporal lobe epilepsy. Animal models have been developed and they are used to understand the epileptogenic mechanisms, so the mechanisms leading to epileptogenesis, and also for the screening of potential new anti-epileptic drugs. Okay. Of course, the models are expected to mimic the different types of seizures that are out there. And when you say different types of seizures, different types of models, you say different needs in terms of funding, in terms of skills needed to implement them. It means that some models will be accessible to low and middle income countries, while others will not be. Give it to daddy. Experimental models include models for generalized tonic-clonic seizures, models for non-convulsive seizures, models for absence seizures, myoclonus models, status epilepticus models, and temporal lobe epilepsy models. The main criticisms about, of these models include the fact that they mostly mimic the disease of pediatric patients and not much the disease of older patients because they lack aging-related challenges. They lack aging-related challenges such as chronic inflammation and dyslipidemia and other problems that can occur with aging. And also the comorbid conditions. So commonly you find hypertension, diabetes mellitus type 2, in Alzheimer, etc. in elderly patients. So these models do not consider that. The other issue is that some of the pathological features do not correspond to human disease because rodents are not small humans. So they have completely different group of animals with their own specificities. Nonetheless, epileptogenesis seems to be, there are enough common features so that anything that will stop even these acute seizures, these chemically or electrically induced seizures, will have also the good potential to improve or the human disease or prevent seizures in humans. So another issue it can be maybe the biggest is that most of the models are acute, so they are not chronic like human disease, so they are less likely to reflect all the features or key features of human disease. The good thing is that these models are continuously improved and new ones are developed. Generalized tonic-clonic seizures model are of two types. There are some inexpensive and that are expensive and require simple procedures. Those will be common in low and middle income countries. And there are others that are expensive and require advanced skills or complex procedure. This will not be very common. So the most common models of generalized tonic-clonic seizure will be electrical stimulations and chemical induction models. Electrical stimulation mainly will be maximal electroshock models. That is transcorneal or transauricular stimulations causing tonic-clonic seizure attacks. Chemical induction is made through with GABA A antagonist or NMDA agonist. Okay, so GABA A antagonists include PTZ, penicillin tetrazole, and fluorotil. They are the most used. Models of myoclonus. Myoclonic seizures are seizures characterized by brief jerk of the limbs, often asymmetrical, and that could occur repeatedly. So the models are mainly of two types. Models induced by injection of PTZ, either subcutaneously or intraperitoneally. This is in birds or in rodents. This approach mimic human myoclonus in terms of the result mimic human myoclonus, and considering that it is inexpensive, and it's a good model. It is commonly used in worldwide and particularly in low and middle income countries. Instead, models induced by corneal stimulation with electrical current, that is, you administer 45 milliamperes for 3 seconds in the cornea, This technique, which induces myoclonus progressing sometimes to generalized conversions, it requires advanced equipment. You do it in mice, you require advanced equipment and good technical skills. Because the procedure, it's a bit demanding. For that reason, it will not be commonly used in low and middle income countries. When it comes to status epilepticus models, we can say that there are two main types: chemical kindling models and electrical kindling models. Chemical kindling models are subcutaneous or intraperitoneal injection of PTZ, kainate, or pilocarpine. And they are commonly used in low and middle income countries because of the low cost and they're easy to perform. Now, another model of chemical kindling is injection of kainate, this time intracortically. That is not very common in low and middle income countries because it requires stereotactic surgery, stereotactic approach, which are not always mastered. I mean, they're not common in low and middle income countries. Electrical kindling models, okay, also require a good technical know-how, advanced equipment, and including for stereotactic surgery. For that reason, they will not be commonly used in the low and middle income countries. Examples are models induced by electrical stimulation of the hippocampus or the amygdala in rats. As it's stated here, you can see stereotactic surgery in progress. Temporal lobe epilepsy model result from an initial precipitating injury. So it is a real chronic epilepsy model. So that after that initial precipitating injury, which may be a mechanical, a chemical, or any of the electrical induction approaches discussed before. So after that initial precipitating injury, you will have a latent period, which in human may last from days, months, years. So after that latent stage, you enter into a chronic stage with a first spontaneous seizures, and then you continue having seizures. And this disease is very severe and it damages the brain. This is a very dangerous form, a very severe form of epilepsy. The problem is, for when it comes to low and middle income countries, that the limitation will be the same as for the methods of induction. So as you mentioned, all the induction methods we cannot, I mean, that are not common in low and middle income countries, will not be used also for inducing temporal lobe epilepsy. So people will stick to the chemical and the electrical induction method that are inexpensive and easy to perform. Other models not common in LMICs will be non-convulsive seizures models such as rats penetrating ballistic like brain injury and blast TBI model. So these are techniques that require very specific sets to be performed and they can be dangerous. For instance, for the blast TBI model, they use explosives. So people need experience to perform that. They need to know what they're doing. Absence share models are not also used or not commonly used in LMICs because they require for some transgenic and related models, which may be difficult to maintain and expensive also to maintain. Now we also have techniques that like induction by chemical kindling agents such as GHB or PTZ. which are controversial, and they have a very high individual and species variability. They're not commonly used because to perform them, you need to know what you are doing and have the means to measure it precisely and be able to get results that are reliable. And this is why they're not commonly used. They're expensive. So overall, we can say that in low and middle income countries, people focus on electrical induction and chemical induction that are inexpensive and do not require special skills. At the end of my presentation, I would like to thank the Brain Africa Research Initiative and the Brain Conference Organizing Committee for inviting me. And I would like to invite you to visit low and middle income countries where there are a lot of natural products with potential anti-epileptic properties that need testing. Thank you for your attention.
At this point, I would like to invite our next speaker, who is Kireshnee Naidu. She'll be speaking to us on the genetic profile of a South African inherited myopathies cohort. Thank you for staying with us.
Good day, everyone. I'm Kireshnee Naidu from South Africa, and I will be presenting some of the preliminary results from my PhD project. So here we will share the genetic profile of a South African inherited myopathies cohort. I am an IGAP research fellow, which is the International Consortium of Genomic Medicine in Neuromuscular Diseases, and also a recipient of the Guarantors of Brain Fund. I have highlighted my supervisors and co-authors' affiliations on this page, which range from the UK and South Africa. And just to mention, I have no conflicts of interest to disclose. Inherited myopathies form a large group of heterogeneous muscle disorders, and now application of next-generation sequencing technologies have made molecular diagnosis possible for many patients. However, access to genetic testing in sub-Saharan Africa is restricted to a small number of conditions, and furthermore, the literature on inherited myopathies in this region is severely limited. So with this in mind, we aim to describe the clinical and genetic features of inherited myopathies in an ethnically diverse cohort of adult patients from South Africa. So here we are at the very tip of Africa, and in particular, we are based in the Western Cape province. We do receive a few patients from neighbouring provinces who have been included, and on the rare occasion, we have patients from surrounding countries. We only recruited patients older than 13 years of age, as we are based at the adult neurology departments of 2 academic hospitals, and recruitment began in March of 2020 and is currently still ongoing. Participants were then classified into a diagnostic category, and genetic testing was performed either through the local diagnostic pathway or through the ICGNMD pipeline. A few patients also had genetic testing through Invitae in the US if they had private funding or were approved for hospital coverage of the cost. There was a tiered approach to genetic testing, some of it being able to be performed in South Africa. We were able to test for expansion in the DMPK gene for myotonic dystrophy type 1. We have access to DMD-MLPA, testing for the common variants in the RYR1 gene and looking at PYGM and CPT2. Southern blotting for FSHD was facilitated by the ICGNMD to have testing in Leiden in the Netherlands. Patients would then proceed as necessary to whole exome sequencing or mitochondrial genome sequencing, and whole genome sequencing is reserved for certain unsolved patients that require further testing. We currently have 110 probams and 27 affected relatives recruited. However, all further results only pertain to the probams. 60% of our cohort are male, and have broken down the groups into their ancestry here. So the largest group was 54%, and those were of European ancestry. 36% was of mixed ancestry, 3% of Indian ancestry, and 7% of African ancestry. And to mention that the mixed ancestry population of South Africa have a very unique background, deriving their ancestry from the Western European, East and South Asian, as well as the indigenous Black African populations. This pie chart demonstrates the different subgroups of inherited myopathies that we have. Limb-girdle muscular dystrophy and distal myopathies form a large number of our cohort, while there are also a significant number of patients with FSHD and myotonic dystrophy. This graph displays the number of solved cases as per their diagnostic category, and while there is a high solved rate in the FSHD, myotonic dystrophy, and dystrophinopathies group, the limb-girdle muscular dystrophy and distal myopathy subgroups still have a high burden of unsolved cases. Bearing in mind, these are only our preliminary results, and we are still awaiting genetic results back on about 40 of our patients. So at that, our genetically solved rate is 88% based on the cases that have been genetically analyzed thus far, and that would be 62 of those patients. So this is a table just to summarize the solved cases we have. From our patients with FSHD and myotonic dystrophy, we have patients of European and mixed ancestry. However, we haven't identified a patient with African ancestry, and I'm currently unaware of a genetically confirmed case in a patient with pure African ancestry with either of these conditions. You'll also note that we have dysphallopathies account for the highest number of autosomal recessive limb-girdle muscular dystrophies in our cohort, in contrast to the single patient with a calpainopathy, and this patient is actually from Somalia. This seems rather interesting, as calpain is still considered the commonest form of autosomal recessive limb-girdle muscular dystrophy worldwide. The other variants in the limb-girdle muscular group were Lamin, Desmin, and OPA1. Another interesting finding is that we identify two unrelated families with a large heterozygous nebulin deletion. And this is really interesting, as nebulin myopathies are considered to be of autosomal recessive inheritance, and there's only been a single publication thus far from Finland of an autosomal dominant nebulin distal myopathy. Our other distal myopathies was in dysferlin, myosin heavy chain 7, and myotilin. We have one family with a confirmed PABN1 expansion in the OPMD group, and the 3 solved cases in the channelopathy group all had myotonia congenita with mutations in the chloride channel gene. We had 4 with RYR1 mutations and 1 collagenopathy in the congenital muscular dystrophy and myopathy group. In the mitochondrial myopathy group, there were 2 with twinkle mutations, 2 with large mitochondrial DNA deletions, and 1 with NOP. In the metabolic myopathy group, we had 1 patient with Pompe, 2 with multiple acyl CoA dehydrogenase deficiency, and 1 with another RYR1 mutation. So in conclusion, we have a genetically solved rate of 88% thus far. While FSHD and myotonic dystrophy are fairly common in our cohort, we have not diagnosed a patient of African or Indian ancestry, though I will note that both those ancestry groups are still a bit on the lower end within the recruitment cohort. Like I've mentioned, we've had some interesting findings, with dysferlin mutations appearing to be the commonest form or cause of autosomal recessive limb-girdle muscular dystrophies as opposed to calpainopathies, as well as identifying 2 families with autosomal dominant nebulin distal myopathies. I would also like to highlight that the collaboration with the ICGNMD has had an immense impact on improving our diagnostic yield and has been an exciting and fruitful venture thus far. We hope that as we continue to recruit and analyze patients, that we will be able to provide further insights into our local population, identify novel mutations, and eventually build in-house capacity to provide a wider range of diagnostic testing here in South Africa.
Again, I would like to welcome any new participants that have joined us in this session on central nervous diseases in low and middle income countries. I would like to encourage the participants to write down their questions, and at the end of the session, you can be able to send your questions to us through the chat box, and we'll have the answers and the discussion during the Q&A session with the presenters. The adoption by the World Health Assembly of the IGAP, the intersectorial global action plan for epilepsy and other neurological diseases gives us a great opportunity to focus on epilepsy and other neurological diseases. We are glad to have Professor Gagandeep Singh with us, who is the president of the Indian Academy of Neurology, and he's going to talk to us about epilepsy in low and middle income countries, the challenges and the perspectives. Let's listen to Professor Gagandeep Singh.
Good morning, good afternoon, and good evening. It's my great pleasure to be here in this online brain conference and to present this topic, which is really very close to my heart. I'm also very grateful to my colleagues, Professor Lysander and Professor Alfred Njamnshi. And particular thanks to Alfred for having chosen this topic for me, which is primary healthcare for people with epilepsy in low and middle income countries. So, ladies and gentlemen, to begin with, let me take you to Calgary in Canada, where this beautiful paper came from and published in JAMA Neurology 2019. The paper examined the impact of specialist care on epilepsy outcomes. And the conclusion of the paper for laypersons says it all. Quote unquote, the level of specialist referral is associated with an incremental reduction in the risk of premature mortality in patients who receive a diagnosis of incident or new onset epilepsy. And the greatest benefits are seen in those who are referred to a comprehensive epilepsy care program. So then, with this evidence, ladies and gentlemen, why talk about primary care? But then let's take you from Calgary, Canada to Andhra Pradesh in South India. And this is a primary health care center in one of the districts in Andhra Pradesh. And this is Dr. Turtupu and the nurse in the primary care facility. These primary care doctors are perhaps the only point of care provision for health for nearly 50,000 people. And if you look at neurology workforce, this is from the WHO Atlas for Country Resources for Neurological Disorders, published in 2017. There are 9 neurologists for 100,000 people in Europe. And in comparison, only 0.3 neurologists per 100,000 people in the Southeast Asian region and 0.1 neurologists per 100,000 people in the African region. And moreover, all of these neurologists are almost concentrated in the capital cities and metropolitan cities, leaving the vast population in the rural countryside completely devoid of neurological experts. And to compound this is the enormous treatment gap. This is from our recent systematic review on epilepsy treatment gap in low and middle income countries. Despite progress made more so in Africa in comparison to Asia, as shown by these two graphs, the epilepsy treatment gap is still formidable, nearly 70% in many of the low and middle income countries. So, ladies and gentlemen, why epilepsy for primary care and why primary care for epilepsy? We know there are 50 million people with epilepsy in the world. Of these, nearly 80% live in low and middle income countries. But the fact is that epilepsy is easily treatable with some simple, uncomplicated regimes involving very simple to use anti-seizure medications. The treatment gap, as emphasized earlier, is wide. Epilepsy is associated with high premature mortality, almost 3 times that of the general population, and it is associated with immense psychosocial consequences, which we are all very well aware. Why primary care? Well, this brings treatment closer to home. It is quicker. It is much more cost efficient, given the fact that the need for specialist training is eliminated. It can be integrated in a complete primary healthcare package with emphasis on prevention. And prevention, mind you, is extremely relevant to epilepsy, because 1/3 of cases of epilepsy in resource-limited countries are amenable to primary prevention. And last but not the least, it reduces the need for specialists. So what do we have in terms of models of primary care for epilepsy? Ladies and gentlemen, let me take you to Malawi in the 1980s. And we have Dr. Watts there, who was an Irish woman, a physician, who came in to a rural hospital in one of the regions in Malawi, North Malawi. And she noted thus in the British Medical Journal in 1989, in Malawi, people with epilepsy spend much time and money traveling from one traditional healer to the other. Various kinds of treatments, including concoction made out of fruits, which is supposed to be had with porridge, but also used in the water for bathing. And mind you, the bathing was not done at the usual place, but in a rubbish pit, emphasizing the discrimination and the stigma associated with epilepsy in the given circumstances. And when Dr. Watts made attempt to establish an epilepsy clinic there, the attempts, in her words, to publicize by word of mouth were at first not very fruitful. And you can see from this graph of patients, the first 3 months there were hardly any patients. Very few people with epilepsy attending the primary healthcare clinic. But then the numbers tipped and the numbers began increasing. And what was the secret behind, or what was the formula behind her success? Well, she had listed it here: publicize the availability of treatment, educate patients and staff, use a simple regime comprising of phenobarbital, no other anti-seizure medications. Extremely important, ensure an adequate and continuous supply of anti-seizure medications which are provided free of costs. And then there were supposed to be monthly review clinics, and ensuring that the patient always sees the same healthcare worker. That consistency is extremely important. From Malawi, we come to India, in North India, where we conducted this community-based cluster randomized trial for epilepsy in resource-limited settings in one district in North India. There were 2 arms in this trial. The first arm received care in the clinic in the district hospital as usual. The second arm received care through community health workers who visited homes, monitored seizures, monitored adherence, supplied medicines, anti-seizure medications, and also counseled people with epilepsy at their homes regarding self-management, stigma management, and adherence. And the outcome was assessed, and this is the comparison of outcomes in the 2 groups. Clearly, the adherence to the anti-seizure medications was better in the home-based care group. And the seizure outcome, initially, the numbers of seizures was similar in the 2 groups, but clearly towards the end of the trial, the seizure outcome was significantly better in the home-based care group. It's heartening to note that there are many such trials and studies and projects which are underway in Africa and also in many Asian countries. And this is something, these are results which we eagerly look forward to receiving. However, there are challenges. We need to look at the forest and not the trees. Primary care health providers deal with an immense number of conditions. The numbers of patients are huge and the number of conditions are huge. And hence, they have to look after acute myocardial infarction, they have to look after anemia, they have to look after pregnancy, they have to think vaccination. And then there are differences in systems, there are differences in culture, there are differences in traditions, there are differences in availability of resources. And hence, it's quite appropriate to conclude that no one size fits all. There is no one model of primary care for all the low and middle income countries in terms of epilepsy care provision. One of the issues is the capacity in scaling up the capacity of primary care workers in managing epilepsy is that they need to be adequately skilled and trained. And it would be great to have a curriculum for training and for improving their skills. The International League Against Epilepsy envisaged exactly this, and it's initiated the development of a primary healthcare curriculum for epilepsy. And this was done by a set of experts, and it went through a series of developments and refinements, the needs assessment, identification of core competencies relevant to primary healthcare for epilepsy, elucidation of the learning objectives, and then we took a online feedback from a global constituency, and this led to further refinement in the curriculum. And the final curriculum is published. It is available online. It is open access and can be accessed in this particular journal. The curriculum itself comprises of 6 domains: diagnosis, counseling, pharmacological treatment, appropriate referral in a variety of situations, the management of emergencies, which is extremely important, and also the management of comorbidities of epilepsy. There are 6 domains, 26 competencies, and 85 learning objectives. This might sound a bit daunting, but it is actually not so, because this is the basic body of knowledge. There is nothing much too detailed about it, but this is the basic body of knowledge which is required for appropriate and adequate management of epilepsy in any kind of setting, be it primary care or specialist care. So we would expect in the domain of diagnosis that people, regardless of whether they are from primary care or specialist care, should be able to understand what is the current ILE definition of seizures and epilepsy, to recognize acute symptomatic seizures when they occur, to identify some elementary semiology and to classify seizures into focal and generalized, do a good clinical examination, reasonable clinical examination for people with epilepsy, do the initial labs, not talking about sophisticated investigations like the electroencephalography and MRI scans, which may or may not be available in most primary care settings. We think it is extremely important that primary care doctors and primary care health workers should recognize status epilepticus, because time is of sense in this particular situation, in this particular circumstance, and time spent in traveling to tertiary care facilities just to receive basic treatment for status epilepticus is time which is lost and which can be detrimental to brain health. So therefore, it is imperative that emergencies, particularly status epilepticus, should be managed as close to the home, ideally in primary healthcare centers, in community healthcare centers, and district hospitals. And this would substantially reduce the burden of care that is put on specialists in many of the low and middle income countries, where neurologists are scarce. The recognition of comorbidities is likewise important, because many comorbidities such as psychiatric disorders, particularly depression and anxiety, can be easily diagnosed and picked up by primary care people. And it is up to the primary care people to understand that comorbid psychiatric disorders are extremely common amongst people with epilepsies, and they need treatment in order to improve quality of life. What are the existing resources? Well, we do have few existing resources which are extremely useful, and I would like to mention a few. The PET courses, the Pediatric Epilepsy Training courses by the British Pediatric Neurology Association, the mental health gap program, which I understand is being revised by the WHO currently, the Latin American E-Initiative for Primary Care for Epilepsy, and in our country, India, we are trying to develop an online package for different cadres of primary healthcare workers. And this should considerably help in scaling up the capacity of primary care personnel to manage epilepsy. Ladies and gentlemen, if I may conclude that primary care for epilepsy can be a success if we prioritize epilepsy amongst policymakers at national government levels as well as state government levels. In these programs, community engagement and the engagement of key stakeholders is really crucial for success. We can consider task sharing versus task shifting, a bottom-up versus a top-down approach, or probably a combination of all. But it's important to understand that no one size fits all. It's important to think globally, act locally, to improvise global solutions and adapt them to the local context and setting. Many thanks, and thank you once again.
Once again, we want to encourage and invite our participants to put their questions in the chat box for the Q&A session at the end of this session. And at this point, we would like to invite Stephanie Efthymiou, who will talk to us on optical genome mapping for the molecular diagnosis of facioscapulohumeral muscular dystrophy, advancement and challenges. Stephanie.
Good morning, everyone. I will be talking about our work on advancing the diagnosis of FSHD using a recent technology called optical genome mapping developed by Bionanogenomics, how we have used it in our lab at UCL, describe our validation study, and what we have learned from it. This was a collaborative study between the ICGNMD consortium set up at UCL, the FSHD clinic at the National Hospital of Neurology, the Leiden FSHD Research Group, and the FSHD Clinic eNames in New Delhi in India. This work has been funded by the ICGNMD, Rose-Trees, and the Innovation Fund. None of the authors have any conflicts of interest to state. Facioscapulohumeral muscular dystrophy, or FSHD for short, is the second most common muscular dystrophy in adults. It affects the face, scapula, and upper arms. Life expectancy can be threatened, and up to 20% of affected individuals become severely disabled. About 95% of cases of FSHD are associated with the contraction of the D4Z4 microsatellite on chromosome 4. The gold standard technique to diagnose FSHD is either southern blot-based pulse-field gel electrophoresis, or PFGE, or linear gel electrophoresis, LGE. However, southern blot protocols can be challenging, and their interpretation requires specially trained staff. Only a limited number of labs worldwide offer a full diagnostic FSHD workup. As a result, other techniques have recently been gaining popularity, and one of them is optical genome mapping, OGM, a technique that can read single unamplified long fragments of high molecular weight DNA with an average length of 300 kb. In our study, we carried out a performance comparison between OGM and traditional southern blot analysis for the molecular characterization of FSHD subtypes in a cohort of around 30 individuals. We used the Sapphire instrument recently set up at UCL Queen Square to evaluate its accuracy and reproducibility to assess the D4Z4 repeat allele size, as well as the A and B haplotypes. We analyzed the data with Bionano's custom and focused FSHD analysis pipeline. We followed the manufacturer's protocol on 2 different cohorts. The confirmed cases were recruited at the National Hospital of Neurology, which were brought to us within a day of collection, and a cohort of suspected FSHD cases were shipped to us from New Delhi in India within 5 to 7 days of collection. We were able to detect the D4Z4 repeat contraction in 22 out of 31 cases and report a positive rate of 71%. D4Z4 sizing highly correlates with data from Southern blot LGE or PFG with a p-value of less than 0.001. The repeat size and haplotype assignment were consistent with a maximum repeat difference of around 2 units. Importantly, we confirmed that using fresh blood from India-based patients within 7 days of collection and transported to us at room temperature is still acceptable for isolating high molecular weight DNA that can be labeled using the manufacturer's protocol. OGM was also able to accurately detect somatic mosaicism on chromosome 4 in 2 cases, resulting in an apparent 5th allele. Interestingly, one of them was not detected by LGE, presumably as it was at a low level to detect by Southern blotting techniques. Interestingly, in one case presenting clinically as FSHD and initially diagnosed as a borderline negative by LGE, OGM was able to accurately measure the contraction size of 10 units on the 4qa allele. We showed here that the presence of 2 10-unit chromosome 4 alleles could explain the clinical FSHD manifestations. Further testing with PFGE has confirmed the data seen by OGM. To conclude, OGM has allowed us to detect structural variants and functionality traits from a single stained molecule of DNA. It significantly reduces the time needed for FSHD analysis compared to traditional Southern blot-based techniques. It is a much better diagnostic tool than LGE on liquid DNA, where, for instance, somatic mosaicism can sometimes be missed. However, high molecular weight DNA from freshly collected samples and highly trained researchers will remain essential for interpreting these results. Hence, further research, as well as health economics evaluation, will be needed to understand if OGM can deliver diagnosis in low and middle income settings. Thank you for your attention.
We now want to thank Professor Lesander for being with us. And Professor Lesander is a global leader in epilepsy with a lot of experience in low and middle income countries. And he's going to give his talk on epilepsy and parasites in low and middle income countries. Professor Lesander, you have the floor.
Oh, hello. Thank you very much for the very kind invitation to come to this brain conference and tell you a little bit about the role of parasites and the risk of epilepsy in poor parts of the world. I'm really pleased that we have the opportunity to discuss this. It's often I ignore a subject when it comes to many neurological meetings. I think that this should be at the forefront because so many people out there could potentially be helped by very basic measures. So without any further do's, let me tell you about this subject. If we look worldwide at epilepsy, it has affected a lot of people, indeed over 50 million people worldwide, most of which are in low or middle income countries. They suffer from epilepsy and their life is often blighted by this condition. Of course, people in the poor countries, they have this double whammy because not only there is a very high diagnostic gap, but it's also a very high treatment gap. There's just not enough anti-epileptic medication produced worldwide to treat many people, all these people with epilepsy. And in many countries of the world, parasites are the major risk factor for epilepsy. And this is something we could do something about in terms of prevention. I think it's also an opportunity to mention a very important part of something that is often put aside when we speak about epilepsy, and this is the epidemiological paradox. This is we know that the incidence of epilepsy is high, particularly in resource-poor settings, both in developing and the so-called developed high-income countries. But it's higher even in resource-poor settings, but the prevalence is not so much different. So we know that epilepsy it's not a benign condition, has a very high risk of premature mortality, and this is an important part of the burden. We have a lot of comorbidities, and overall, it's fair to say that epilepsy is one of the most stigmatized conditions if we look worldwide. And this is even so more the case in poor parts of the world. Now, this high prevalence of comorbidities are an important part of the burden. And it's even more the case in poor parts of the world. And part of this there could be the role of infections and infestations. And I think we cannot actually put aside the fact that comorbidities are a very important part of the burden of epilepsy. And one thing I always say is that, the first mantra in epilepsy is it epilepsy? So misdiagnosis is rife. So we should always ask, is this indeed epilepsy? But the second mantra, once we have confirmed a diagnosis of epilepsy, should be epilepsy and what else? Because having epilepsy should increase the suspicion that something else is going on with this person. And therefore, comorbidities are such an important part of the problem imposed by epilepsy. We tend to talk about causes of epilepsy, and that really makes often my blood boil, because what we should be talking about risk factors. And we know that risk factors, they change from area to area. They could be different in different parts of the world, different ages. Risk factors and the young age is different from the sort of more senior citizens. For instance, the sort of developing brain is where you see a number of these developmental problems, encephalopathies, for instance, where you tend to see major insults in early life coming out as seizures. Whilst, for instance, in the older age group, cerebrovascular disease and probably dementing conditions are an important part of the problem, and are likely to be the sort of major risk factors in this age group. However, an important part of the world, and this sort of tropical belt, we have endemic infections which are associated with epilepsy. Of having it may increases the risk of developing epilepsy, and these include, for instance, malaria, particularly falciparum malaria, neurocysticercosis, or the pork tapeworm. We have onchocerciasis, which is trending at the moment, and it's becoming the circumstantial evidence coming to suggest that this is also an important player. And we have some other, like paragoniosis westermani. We have some other parasites that have been associated with epilepsy, but these are the three biggest players. So going back to this issue of the paradox, I think it's no doubt that we have a class divide in epilepsy, with poorer people being at higher risk. For instance, overall in the high income countries, the incidence is about 50 per 100,000, whilst in resource poor countries is more than double of that. And there have been figures as high as 190 per 100,000 been reported. And this not only in the sort of developing world or low and middle income countries, but it has also been shown that you are a less privileged part of society. In a high income country, your risk of developing epilepsy is higher. So epilepsy is clearly a condition where we have social determinants of health playing a role. And I think that this is really important that we take into account. And an important part of this burden is likely to be driven by parasites and infestation. But of course, if you're poor in some poor part of the world, you're more likely to have traumatic brain injury. That's another risk factor. Deprivation, social factors, and there might also be genetic factors out there. But what we know is that being poor and therefore is a risk factor, bringing in this whole issue of social determinants of health. Now, the prevalence of epilepsy, regardless of where we are, tends to be between 4 and 10 per 1,000 in the population. It's usually higher in rural areas, maybe suggesting that they might be, for instance, if you are in the slums of Rio de Janeiro or Lagos or Delhi, and you develop epilepsy, you might be shipped back to your village, and therefore there might be higher prevalence due to this in some places. But probably there is also good evidence that environmental problems like parasites could be playing a role. What here we need to remember, the paradox is that the numbers we see with the incidents, they're not really what we would expect from what we would expect in terms of prevalence. There is a discrepancy out there. And the most likely players here is in the role of premature mortality, which are bringing down the prevalent cases. But also, we know that some of people that have epilepsy with some parasites, overall, they have a good prognosis. That's the case, for instance, with many people that have epilepsy as a result of exposure to Tinea solium. They could be also playing a role because they tend to go into spontaneous remission. And we all know conditions that this seems to be the case, and that might be part of the problem. Just to reinforce this message that epilepsy is not benign, it's really malignant. It takes a lot of years of people's life expectancy, and we should remember this. And this seems to be more the case. We go to resource poor settings, and some of the figures that come from some rural areas of mortality, premature mortality in epilepsy, are staggering high. So we need to keep that into mind, particularly if we were to do something in terms of prevalence. Now, if we looked at the global distribution of parasitic infections associated with epilepsy, we see it that is really in the around the tropical belt, and the major culprits: Tinea solium, the pork tapeworm. We have onchocerciasis, which is Onchocercium bovilis, which is a cause of river blindness, and malaria, particularly falciparum, which actually if someone has cerebral malaria, falciparum malaria, they survive, there is an increased risk of having neurological disability and epilepsy. Now, let me just mention the culprits here. The largest, probably the commonest avoidable risk factor for epilepsy worldwide is when humans are the intermediate vector, the intermediate sort of the intermediate in the lifestyle of the Taenia solium. This is normally what happens is that pig eat the eggs and develop cysts and muscle and subcutaneous tissue, and then men, women, children eat pork uncooked or raw, and they end up with teniasis. However, when the male men get cysts, for some reason there is a tropism for the brain, and often what we see is that people will develop what's called neuropsychosis, because in humans they seem to be this tropism, neurotropism. The bugs, they go to the brain. Then we have the onchocercium volvulus. It's been increasingly been associated with epilepsy, and all the circumstantial evidence seem to support this. We don't clearly have the physiopathology of this yet, but we're going to hear more and more about this. There's a large trial ongoing in Tanzania now, treating people, making twice a year, treating anti-worm, deworming humans, to see if this will have an impact in the incidence of epilepsy in this part of Tanzania. Then, of course, a big player as well in the risk of epilepsy is Plasmodium falciparum. And when this is complicated by cerebral malaria, and if people survive, there is a high risk of epilepsy as a sequela of this problem. Not only epilepsy, but other neurological deficit are seen, cognitive problems. So you could argue that all of these could be prevented. And what could be done in terms of preventing this could have a major role in decreasing the burden of epilepsy worldwide. I think we need to remember that there are many parts of the health-seeking strategy and involves, let's put it that way, parasites and interaction community we do not fully understand. But it's very important that we try to replicate the care standards we have for epilepsy in high-income countries, where the majority of people, if diagnosed and if treated, they become seizure-free. And we should try to do this everywhere. And I would say that, as I said many times, the resources spent on developing yet another antiepileptic medication could have a much bigger impact on the burden of epilepsy if they were diverted to basic sanitation in these endemic areas. And I think that this is something what society should be asking. What should we do about this? So the key points I hope that you may take away from my talk is that infestations, parasites are a preventable risk factor for epilepsy. Indeed, if we could separate, or we could increase or improve basic sanitation, we could have a much higher impact on the burden of epilepsy. I think it's fair to say that we have treatments for all these parasites. However, we do not know if treating the parasites would have a long-term impact on epilepsy risk, because we have not yet have the studies looking at this. But we should more and more think about how we're gonna impact on this by improving sanitation, by separating bad insects from humans. And because it's clear at this stage that only primary prevention is the only viable approach to reduce the resulting epilepsy burden. And this is really a big issue. So I hope that I was able to convince you that parasites play a role in the risk of epilepsy, and we could have a major impact on the burden that they cause by improving basic sanitation, and some very, very primary measures in many parts of the world. Thank you very much for listening.
Thank you very much. I want to express gratitude to all the speakers. And at this time, I would like to invite my co-chair, Professor Gagandeep Singh, to handle the question and answer session. Professor Singh, please.
Right. Do we have any questions? If there are none, then I might actually ask questions. Are there any questions? No. So I'll actually, right. There is a question for Kireshnee. A lot of genetic research in South Africa is demographically skewed towards those of European heritage. So how much of this skewing in your data do you think is related to the access of genetic testing and diagnosis, lower prevalence of genetic diseases in African patients, or unidentified variants? So is that the case in your study?
Okay, so thank you for your question. I don't know if I can give you a completely clear answer yet, because it's still something that we're trying to work out. But I do think there's there's multiple factors to it. And so while I think that there may be some disparity in access to healthcare between the different racial groups, or even maybe cultural biases as how they use healthcare, the fact that we're not seeing any patients of African ancestry that have FSHD or myotonic dystrophy, which are some of the commonest muscular dystrophies worldwide, would suggest that there is also an underlying suggestion that maybe certain genetic muscular dystrophies are not seen in the African population that also affects it. And I think it's a result of multiple factors.
Thank you. And there's one question for Stephanie. So can you use OGM for diagnosing type 2 FSHD?
So diagnosis of FSHD type 2 is established in an affected proband by identification of hypomethylation of the D4Z4 repeat array. And this cannot be done by OGM. You would have to use a southern blot-based technique with a restriction enzyme, specifically the FSE1, which directly cuts at the promoter region of the DAX4 region, and you'll be able to see whether you have reduced levels of methylation.
Right, thank you. There are a couple of questions for Lei, but I cannot see those questions. Right, yes, I can see it now. So is it possible that some of, well, this is probably not for Lei, it is for Stephanie only, is Chan Nagpalas. Is it possible that the bulbar manifestations do occur in facioscapulohumeral dystrophy and in patients with severe facioscapulohumeral dystrophy? And could early onset facioscapulohumeral dystrophy contribute to a more severe clinical type?
So FSHD can go on to affect any skeletal muscle, but typically it spares the extraocular muscles or the cardiac muscles and the bulbar muscles. And I'm not a clinician, but I think the early onset FSHD often is linked with severe muscle weakness and systemic features, which is kind of more severe than patients with the classic onset of FSHD.
Thank you. Thank you. So, Lei, Dr. John Duncan is asking this question to you. You mentioned value for money. Complex epilepsy surgery may cost up to 70,000 Great Britain pounds, 50% chances of cure. How square is this with the global treatment gap? Lei, that's for you from John.
Yeah. Hi, John. I think it's a very loaded question. If I were a public health person looking at this, I would say doesn't square at all. And the reason for this is that the population with epilepsy, even in that would be suitable for epilepsy surgery,
it's not likely to be more than, let's say, 20%. With a $70,000, I could probably treat quite a lot of patients for a long time, make them seizure-free 70% of the time. So I think that from that point of view, I would not start straight away a desert island, resource pool, a desert island, an epilepsy surgery program. However, I think it's very important to have this as part of the armamentarium. There should be no doubts from a epilepsy and a neurologist and a humanist. We should have epilepsy surgery programs. And for the people that this would make a difference. I think that one question that you would have is that if in many places what could be remainable with a surgery will be the so-called low-hanging fruits. And I suspect that in that group, the chances of becoming seizure-free are much higher, are probably 70%. So I think that, yes, there should be a place. I don't think that this will be the solution for the treatment gap, but epilepsy surgery, all options of epilepsy treatment should be available for people around the world, and this is very much the case in low and middle income countries.
Thank you, Lei. John has asked another question, and it is outside of a trial, do you think you could have a specific primary care epilepsy service? Would it be viable given all the other healthcare issues in people who actually visit the primary care centers? And I think it's a very, very, very relevant question. There is this big issue, and John, Lei, myself, and others, we have this implementation initiative in 3 Indian districts, and we're trying to look at exactly this. And there are huge, huge challenges. We're facing huge challenges. People with epilepsy often do not go to primary care services, because for a multiple number of reasons, there is the issue of availability of medicines. So there are essential medicines which are supposed to be available but are not actually available in the primary healthcare centers. We just visited one primary healthcare center today as a part of our project visit, and we just couldn't find the primary healthcare doctor there. There were other staff members, but the doctor would seem to be missing there. And so these are some of the issues that we face and which probably need to be overcome. And of course, I think your thoughts are extremely, extremely pertinent. A primary care doctor has to look after so many things. He has to look after acute myocardial infarction. He has to look after bacterial vaginitis. He has to look after deliveries. He has to look after, they do deliveries in many of the primary care centers. They have to look after vaccination for kids. So epilepsy, how does it figure in this entire big thing? And then the issue of numbers of patients and time available with the primary care doctor. So these are some of the challenges. But I think the bottom line is there aren't enough specialists. There aren't enough neurologists. This is amply clear. And the case is in some of the low and middle income countries, particularly in Africa, there are absolutely no neurologists. And then someone has to take care of them. And then who would take care of them but the primary care doctors? There are primary care centers in certain countries where the only person running the primary care center is a nurse and not even a doctor. So at least they might be able to provide some care and some kind of medication, some kind of help the people with epilepsy to some extent.
I think it's a very important point. And but this is why epilepsy needs to be integrated in the existing infrastructure of primary care. And that is the challenge.
Yeah. More questions? Right. So the other question is, the study about primary care where phenobarbital was used as a standard medication, I wish to understand the rationale behind using a single medication which has bad side effects, and is there a specific benefit from this particular medicine in primary care settings in low-income countries? So I think the answer for that is very simple. Quite often it is the only medicine that is available, and it's better to give that medicine rather than depriving the patient from taking anti-seizure medication. So that is the answer. Lei, would you like to add to that?
Yeah, I think that the problem is that as many drugs, you give a drug or a dog a bad name, it sticks. Phenobarbital, usually people respond to low doses. And low doses, and there is quite enough evidence out there that low doses of phenobarbital will make people seizure-free with very little in terms of cognition. So I think that, and we need to be very, let's put it that way, non-nihilistic here, because phenobarbital is the only option. If you were in a country, and this is the average expenditure for healthcare in many places in sub-Sahara Africa, it's about less than $40 a year. If you want to actually now use a drug that is going to be more than that, it's just not going to work. So we need to actually try eventually to have the right drugs at the right time for everyone. But at this stage, at this point in time, I think it's unethical not to do something. And phenobarbital in low doses can make a difference for a number of people. And the studies show that 50% of people exposed to low doses of phenobarbital as the first drug, it does seem to work. So I think that that's the rationale that I would say that until we have a cheap drug that has better profile, we need to stick to phenobarbital. I think that that is how I see it from an ethical point of view.
Right. The next question is, we can probably classify barriers to primary care as supply side and demand side. How can these be approached? Yeah, I think that's absolutely correct. And, you have supply side barriers where, the availability of anti-seizure medications can be an issue. The availability of specialists, the availability of primary care doctors, the administrative issues. So these are all supply side barriers. And then there are demand side barriers, and demand side barriers might be, for instance, the distance between or the access to the healthcare facility. And then you could have demand side barriers in the form of attitudes and beliefs. So a huge number of people might not believe in the Western style medicines, and they would, if you look at pathways of care for epilepsy in some of the resource limited settings, you would have people going to quacks, people going to witch doctors, people going to indigenous medicine specialists, and so on and so forth. So attitudes and beliefs of people is a very, very important stigma, of course, and discrimination, and the fear of going to a hospital facility and being diagnosed with epilepsy and being given a label of epilepsy prevents many people in resource limited settings from accessing healthcare. So these are good examples of demand side barriers. And of course, each of them needs to be approached individually. And as we discussed earlier, there are these issues which vary from community to community, from one geographical region to another, from different cultural settings. So I think the bottom line, as I said earlier, is no one size fits all. We need to reduce the treatment gap, but we need to use local resources, innovate locally, and adapt locally to the local cultural context, the socioeconomic context, and then try to bridge the treatment gap. Lei, would you like to add anything?
No, I would agree. I would agree with that. I think it's a very important concept that We cannot actually just bring a black box. We need to adapt to local circumstances. We need to always, and that is what provides sustainability for any approach. If you plant it within existing infrastructure, and you could argue that then you have to improve, you know, and worldwide, if we want to do something, we need to really integrate epilepsy care within primary care. At this time, that's the only option.
Alfred, would you like to add to this?
Yes, I would like us to consider, when we look at Paul's presentation on experimental models, and also when we consider, for example, in Africa, the rich traditional pharmacopoeia for epilepsy, which is underdeveloped, and looking at the primary care model that you've excellently talked on, how can we go forward from here, combining especially within the background of improved traditional medication that the WHO approves? How can we, with Paul together, think of moving this forward, knowing that some of the medicinal plants that have been studied in Africa and in the low and middle income countries are not yet available in form of cheap and accessible improved traditional medication? And these are often manipulated by the traditional healers. And I think that if we engage them, how can we move forward with this, given your experience, all of us, especially considering what Paul presented to us? How can we use that to move forward?
Paul, would you like to? What is
Yes,
the way?
yes, thanks very much. My first observation, I mean, I really agree with what Professor Njamnshi said now. The big issue we are having is you do a very fantastic work at the bench. Now you publish it, and then you get stuck because you do not have the means to go for preclinical studies. And in many countries, they are protecting even some plants, you know, what to work on, and they are not even allowing you to collaborate. But without a mechanism of action, or at least an idea of mechanism of action, how can you put it on the market? Because how can they anticipate interactions, drug interaction, the drug, I call it, yeah. How could they anticipate that? How could they anticipate the problem that will happen clinically? How can I know how to stop? I mean, an excess, for instance, if a patient overtake that drug, how can I stop it? What is inside, pharmacologically speaking? And we don't have the resources to do that. And I think we started a very good work with India in South-South collaboration. We managed to, Indian shares the experience with us. I mean, cheaper best. We managed to get a lot on the way, but then you reach a clinical trial level. In many countries, the structure in Africa, in low and middle income countries, the system is not structured for clinical trials. And if you have to, you have a disease that is endemic to a specific area in Africa, for instance, and you have no structure for a good clinical trial. So I think that, to my opinion, we should emphasize some South-South collaborations and find ways to collaborate. Yeah, thanks.
Hello?
Yes.
Yes, I would like to hear your comments on that.
Right.
Gagandeep and Lei, what are your comments on that?
Yeah, sorry, yes, Lei, after you.
No, I think that is a very, very valid point. In the series of the very different ways of looking at this, we should always have the best everywhere. We are all humans, and we should have the equal access to everything. Research resources should be distributed equally, and we all should have equal access to the best drugs, to the best diagnostic. But the reality is that people will have other priorities, and this is really based on the resources that are available. And health as in research it's a cost opportunity. If we use it for something, we cannot use it for somewhere else. And often the question is, what should be the priority? Many countries may choose that the priority for the, let's say, $40 of allocated per capita money for health will go into immunization programs. It might go to maternal and child health. And this is where we have the big problem. How do we make increase what is available so the distribution could be more equal? And this is really something that I don't have a solution at the moment. I wish I had, because this is what leads to people feeling frustrated. That leads why people sometimes want to move from one place to another. This actually brings a lot of frustrations to everyone. But at the moment, the solution is not out there, and we should work to improve this to get to a nearer solution as we could. Would you agree with that, Alfred?
Alfred is muted.
Right. Yes, there is a lot of work to do, and the challenges are there. And I'm glad that you touched on the reality. There is the principle of equity in health, but the reality is that we are very far from that. And if I go back to your principle of being ethical, then maybe we need to work to see how we can make what is available better and usable. I mean, and who knows? Some of those, if we work on some of those, we might have better treatments that are better tolerated from some of those medicinal plants.
Yeah, I also think it's important to engage the herbal doctors for the simple reason, in epilepsy care, for the simple reason that many of the people in the community have a lot of faith in them. And they would actually listen to them and take their views. And therefore, I think in community epilepsy programs or primary epilepsy care programs, we need to engage the community doctors. We need to engage some of the herbal specialists, because there are people who have absolute faith in them, and they would consult them in preference to great super specialists, So I think they do have a place, and we need to treat them with respect. And I mean, there are many things we don't know about herbal medicine, but I'm not a follower of herbal medicine. I'm not a protagonist of herbal medicine, but I think herbal medicine specialists need to be engaged in community. That's the other way of looking at it in any kind of community epilepsy program. Right. So I think there are no other questions. We have a couple of minutes left. Just one quick one for Paul. Many of these infections, for instance, cerebral malaria and neurocysticercosis also, these are kind of natural models of epilepsy and epileptogenesis. You can predict, you can actually estimate the date of infection, the initial infection when brain was colonized, and then you can estimate, or you can find out what is the time at which the first seizure occurs. Then chronic epilepsy, enduring epilepsy is encountered, and then when epilepsy becomes drug resistant, if at all it does. So do you think this natural model needs to be studied a little better, and that might be something that we could gain some unique insights into the mystery of epileptogenesis?
Wow. Very interesting question. We are already doing that with Toxoplasma and Onchocerca.
Right.
And what I can say is you need to be a very good expert to observe seizures in an animal, because they're not only clonic seizures, you know. For instance, you can have absence, you can have nodding, and you really take experience to see that. But I think it's a good approach. We observe some animals with pus in the brain, you know, pyogenic abscesses, but still there were manifestations were not obvious. I mean, the behavior, we monitored animals for 24 hours for about a month. So to my opinion, I think that here also it's a new way, a new approach. We can find functional ways of measuring the effects, not necessarily seizures. It may be, I don't know, some locomotor issue or any other. And you can use that now for testing for testing your for screening drugs or potential drugs.
Thank you.
I think that this is
Alfred, would you conclude? Because I think it's time. Just thank you, especially to Stephanie and Kireshnee for the wonderful presentations. Right.
I want to thank all the speakers for the excellent presentations, and I thank our participants for the excellent questions, and thank you, co-chair Gagandeep, for handling the question and answer session. And I want to thank also the organizers of this brain conference for giving us this opportunity to organize this session. And I want to thank particularly Professor Tara Spiro-Jones, Editor-in-Chief of Brain Communications, for inviting us to have this together. And I would like to invite and encourage our participants to continue in the conference, look at the poster sessions, and look at other sessions that might be of interest to them. And let's keep on the conversation. Thank you very much for the speakers and participants. Bye for now.
Bye.